Every day, we get to help people with the most precious sense known to mankind, and that's sight. Are you considering that patient's lifestyle? Are they a plumber? Are they a teacher? Are they an engineer? What do they do for a living? What hobbies do they have? Are you considering lifestyles? If not, you need to tune in today because we're talking about that. Let's go. This is a Defocus Media production.
Audio Jungle.
What's up, everyone? It's your favorite optometrist, Dr. Daryl Glover.
And I'm Dr. Jennifer Lyerly, resident optometry nerd.
And welcome to Defocus Media, optometry's #1 podcast, where we discuss the hottest topics, latest technology, eyewear, practice management, and more. So sit back, relax, and defocus. What's up, everyone? It's your favorite optometrist, Dr. Daryl Glover. Super excited today because we have another incredible show. And today's show, I'm super excited because we're going to touch on something that is very near and dear to my heart, and that's considering what patients do for a living, their lifestyle. So we're going to have a real conversation. We have a team of experts. We have the one and only, the one that I adore and love when it comes to any professor out there, Dr. Erin. How are you doing today, Dr. Erin?
I'm great. Thanks for having me back, Daryl.
Thanks so much for, taking the lead and taking the charge on really educating the future, educating our students, our new graduates, and some of us seasoned ODs that need a little knock on the head to remind us about what we need to be talking about in exam lane. Thank you so much. And then we have the one and only Dr. Gaby, who's doing everything from legislation to educating about contact lens in that exam lane, and entertaining everyone out there in the eye care space because she just has that secret sauce to take that patient care to the next level. How are you doing today, Dr. Gaby?
I'm doing awesome. I'm excited for our case today and to talk about some interesting things.
Yeah, I'm super excited as well, especially just to hear all the knowledge and the tips that you're going to bring to elevate what I do in the exam lane along with my colleagues and the students out there. And then last but not least, we have a student with us. We always like to bring a student on to engage and socialize a case to take their skills to the next level with a team of experts. And tonight's guest is Ryan Kobayashi. How are you doing today, Ryan?
I'm doing great. Excited to be here. Thank you for having me.
Hey, man, we're super excited to have you. And, we were chatting a little bit prior to going live, and I was asking you a little bit about your background, but I want the whole world to know who you are. So if you don't mind sharing a little bit about your background and maybe a fun fact as well, my friend.
Yeah, of course. So my name is Ryan Kobayashi. I'm a third year, going into fourth year now at the Southern California College of Optometry. I was born and raised in Torrance, California, and I did my undergrad at Boston University. In terms of fun fact, I guess maybe I was on the ski team in Boston University, so I don't look like it, but I did ski. I do ski a lot, so that's my fun fact.
Hey, man, I'm nervous to get on any kind of slopes, man. I've never skied in my life, and I told myself at some point in time I'm going to make it happen, but I'll live through you until that time comes. But man, you got a fan club out here tonight, my friend. Everyone's like, "Yay, Ryan! I go to school with that guy. Yay, go Ryan!" Wow, ski team. I guess you're dropping gems that they didn't know about you as well, my friend. So super excited to get this party started. For those that are new to this series, I want to thank our partners over at J&J, Johnson & Johnson Vision. They have done a fantastic job with really pushing education forward for our students, fighting for our rights when it comes to legislation, but most importantly, making eye care a better space. So I want to thank Johnson & Johnson for this partnership with Defocus Media. How we're going to get started is basically with Dr. Erin and Ryan talking about a case. So we're going to switch it over. Myself and Dr. Gaby are going to tap out. So we'll see y'all later. Oh, and we are going to give some gift cards away. So stay tuned till later.
All right. Okay, let's see. Okay, I think I see the slides up here. All right, Ryan, we're going to get started. Thank you so much for coming on with us today. As Ryan said, he's getting ready to transition from third year to fourth year. So next week starts fourth year rotation. So I know there's a lot going on for you, for a lot of people in the audience. So I'm glad that you guys were all still able to kind of tune in and hopefully kind of hone our skills with our contact lens patients. So thank you again to Johnson & Johnson for sponsoring this whole series. We're kind of coming to the end of this year's series of Grand Rounds. So we want to thank our partners at J&J who have been so generous to help us kind of get this up and running. All right, so let's get started here. Tonight, we're going to present a case that we've titled Vision and Comfort, a Lifestyle. And tonight, I think we'll cover a lot of some of the pearls that we've talked about this whole series, and overall sort of bring it together to highlight how we kind of have to think about every unique aspect of our patient clinically and also from a sort of personal lifestyle perspective in order to determine a best treatment plan for them so that their vision and comfort is maximized all the time. So let's get started here. This is a pretty typical patient that we'll see in a soft contact lens practice. We have a 24-year-old Caucasian female coming in, and she's saying that her eyes are just generally uncomfortable. She gets eye strain. She's a medical student, so she's doing a lot of studying. I'm sure everyone who's listening can relate to that, right? Doing a lot of near work, kind of bouncing between tablets, computer screens, phones, noticing eye strain, intermittent blurry vision. She reports that she does have some redness occasionally and irritation, but she doesn't really do much for it. She kind of crosses her fingers and hopes it gets better. Sometimes she'll replace her contact lenses more frequently to hope that that kind of helps alleviate both some of the discomfort and the redness. Speaking of contact lenses, she wears a 2-week replacement lens. She's worn this lens kind of for as long as she can remember. And she's good about compliance in the sense that she doesn't wear it more than 2 weeks. But again, sometimes she's finding herself replacing it more often in hopes that that will sort of help her discomfort. When we look at her sort of visual stats here, she's coming in wearing, like I said, a 2-week replacement soft lens. It's a -350 in both eyes. She's seeing okay out of it, sort of a soft 20/20. But when you do your manifest refraction, you notice that that right eye actually has a good amount of still, a diopter there. And the left eye is pretty spherical. And you ask her if anyone's ever mentioned that to her before. And she actually says that in the past, she kind of liked having the same powered contact lens in both eyes, as we can see that she's wearing here. And so she just sort of maintained that over the years because it just makes her life a little bit easier. When I look at her anterior segment data, again, nothing crazy here. This is what I would consider sort of typical and what we see in a lot of patients these days. Grade 2-ish meibomian gland capping. The meibum isn't looking great. It could probably look better. You're seeing some mild telangiectasia, a little bit of injection. And when you measure her tear breakup time, you can see that it's just inconsistent. It's generally low, but also inconsistent, going from 5 seconds to 2 to 4 to 6, just kind of all over the place there. So that's sort of her pertinent refractive and clinical data. So based on that, Ryan, what would you say is contributing to both her visual complaints and her ocular surface or ocular discomfort complaints?
Mm-hmm. Yeah, so the first thing I kind of noticed was the stigmatism in the right eye. Especially she's wearing a spherical contact lens, which really doesn't correct for that. So I'm thinking maybe the residual uncorrected SIL may be causing some of that visual discomfort. I think it's also important to know, as you mentioned, that she is a medical student. She's probably doing a lot of studying, especially at the computer, probably not blinking as much as she should have, maybe wearing the contact lenses a little bit more than she should, probably a longer time than 8 hours a day. So I think all that in combination may be probably causing some visual strain. In addition, as the anterior segment showed, she definitely has some dry eye. So I think all those combination of factors definitely probably are contributing some of those dry eye and visual and ocular complaints that she's been having.
Exactly. Yeah. The story you just kind of told went from vision to ocular surface. And sometimes it's hard to kind of tease out where one ends and the other begins. And so I think you're totally right. And for this case, we are going to talk about how you kind of have to consider all of those things together and change how the patient is sort of addressing her visual correction and her ocular surface health. So let's talk first about that sort of ocular discomfort. So if we're kind of looking really objectively at sort of the ocular surface and the relationship between the contact lens and the ocular surface, you mentioned a lot of these things. Meibomian gland health and function could definitely be improved based on what we're observing today. And by improving that, that will probably help with her tear breakup time and general tear stability. She's wearing a 2-week replacement lens. She's replacing it more often than every 2 weeks. And so while, it's easy for especially like if you have a student come in, you are tempted to maybe prescribe them the least expensive option, but that is not serving her in this case. And we want to start talking to her about a daily disposable option to, as the title of this talk would suggest, sort of change her lifestyle to help improve her ocular comfort. As well, she's not really doing anything to address her irritation. Besides increasing replacement frequency, she needs to start a more consistent routine associated with her ocular surface. So, to specifically address the ocular discomfort here, I'm going to suggest she first gets on a good sort of routine of daily lid hygiene. I found for my patients that it's good to suggest warm compresses. Those are sometimes more difficult to really implement in real life, but I found that doing just regular lid hygiene, at least at nighttime, um, or I should say, at least one time a day, whether it's at night or in the morning, whatever they can realistically do, does help to sort of improve meibomian gland health and function. I've said multiple times in these Grand Rounds presentations that I really like to talk about proactive artificial tear use rather than just reactive. So I'd want to get this patient started on a sort of every day, 2 or 3 times a day, getting in an artificial tear, whether her eyes feel irritated or not. And finally, again, as I've already mentioned, adding to the change in sort of lifestyle and lifestyle routines, getting a daily disposable contact lens modality in there. So the first thing we're going to talk about is changing her habits and routines associated with contact lens wear. Again, that's going to start with hygiene, lubrication, and initiating a daily disposable lens. Next, we're going to address the visual discomfort. And I love talking about visual discomfort because I feel like it's a really under acknowledged cause of discomfort in our contact lens wearers. And specifically, uncorrected astigmatism is something that so many patients are dealing with and probably suffering from a level of discomfort associated with uncorrected astigmatism that this is a great patient to kind of talk about. So we're going to want to get her in a toric lens for that right eye to help alleviate some of that eye strain and give her better clarity and consistency with vision, no matter what she's looking at. Now, there's probably people listening from all sorts of schools and practice types out there. And, somebody might have told you in the past, oh, if they only have a diopter of astigmatism, just take the spherical equivalent of it and move on from there. But there's actually really good evidence out there, and I won't read all these. I know there's a lot of words on these slides. This is clearly a heart topic of mine, right? Like I'm very passionate about this, but there's a lot of evidence out there that shows that our low astigmats actually really do benefit from wearing a toric lens instead of a spherical lens in their eyes. So those people who have, 0.75, 1 diopter of astigmatism, not only does their visual acuity improve with a toric contact lens, but things like visual function. So things like contrast sensitivity, vision in low light and glare conditions improve with a toric lens. And most importantly, those low astigmats actually prefer a toric lens when compared to a spherical lens. So even if they're able to achieve 20/20 vision, they subjectively prefer the toric lens. One study that I thought has been really interesting in the last few years actually corrected low to moderate astigmat, so 0.75 to 0.15 diopters with spherical compared to toric lenses, and had them look at an iPad. So they actually had them look at a screen. And they reported that when the patients were wearing the toric lenses, they had better high and low contrast visual acuity. The patients had to zoom in less on the text. And probably the biggest headline from this is that 85% of those low astigmats preferred looking at a screen when they were corrected fully for their astigmatism. So if that doesn't convince a practitioner to, try that toric lens, I'm not sure what would. Another really interesting trial found that, again, sort of what we've talked about at the beginning of this case is that it's sometimes hard to separate ocular and visual comfort, but patients who had better subjective vision, so patients who liked the vision better with whatever lens they were wearing, be it a toric lens or a spherical lens, also felt that the lens was sort of more comfortable ocularly. They reported better ocular comfort. So visual comfort is related to ocular comfort. They are the same thing. They're hard to separate. And so by maximally correcting our patients' vision, we're also going to maximally correct their comfort. So that's why it's so important in this case to make sure that we're prescribing a toric lens for that right eye, even though she only needs a lens in one eye. Even though she likes having the same powered lens in both eyes, it's going to be better for her from an overall comfort standpoint to do the toric lens. So changing her lifestyle in the sense of making sure we have a toric lens in the right eye, again, doing a daily disposable option, and getting on that proactive artificial tear and lid hygiene routine. So we implemented these things with this patient, and she comes back 2 weeks later and she actually says her vision, like clarity wise, seems the same to her. So subjectively, she feels like the vision is the same between the two, but she does notice improved eye strain at the end of the day, which we could hypothesize could potentially be due to that toric lens. And she's finding that the lid hygiene habits are coming. It's easier for her to do them at night. But this is an important reason to kind of note that after you kind of tell patients, hey, do these artificial tears, do lid scrubs, things like that, it's good to check in with them a couple weeks later and have kind of a gut check of what's working, what's not, and kind of have a moment to remind them about sort of why we implemented those changes and, you know, how they can continue them moving forward. So I guess I want to bring Dr. Gaby in next, and I want to talk to her about the decision on a toric lens here, specifically how you might choose a toric lens for a patient like this. And I kind of just went off on a soapbox about how important it is to prescribe toric lenses for, especially for low astigmats. But I'd be curious what Dr. Gaby's thoughts and kind of clinical experiences with those types of patients, and what she thinks. So she's back, she's here.
Yeah, so first off, I always look at the amount of astigmatism that the patient has. A lot of studies, like you had said before, has shown that even if you leave one diopter of uncorrected astigmatism, it can impact many things, including reading speed, reduced reading fluency, and also reduced stereo acuity. So all these things can lead to contact lens drop off. So maybe some of our patients that we were fitting in a spherical lens ended up not liking the contacts because their vision was not fully corrected like it should be. I think it's important too that, you know, the way that we prescribe contact lenses should be no different than the way that we prescribe glasses. You know, if we find 0.25 SIL in glasses, we're going to prescribe it in our, you know, in our manifest, we're going to prescribe it in our glasses. So I feel like with contacts, it should be no different. You know, sometimes people find that fitting astigmatic contact lenses can be challenging. Maybe, you know, they have less of a success rate. So it's really important for us to nail down, well, why? How can we become better fitters? And there's a lot of different things that can impact the way a contact lens fits on the eye. So obviously we have to take into account the way that the lid interacts with the contact, right? We have to make sure that the lens is stable, that there's no rotation on that lens, especially when the patient is blinking. And then lastly, how does that contact lens react on the eye when we have these swift eye movements and head movements? So those are three things that I do consider when prescribing astigmatic contact. I think too, you know, it's important to remember that these toric lenses, each company has their own way of stabilizing the lenses on the patient's eyes, right? So I don't know, Ryan, have you heard different types of designs used to stabilize contacts? Do you remember any of them?
Excuse me. Yeah, of course. I think we've all heard of like the ones that are thin at the top and the bottom to kind of keep the lid and hold them in place. That's the one that comes to mind most. I know there's some like, they kind of set it heavier on the bottom so it stays there and doesn't really rotate well. Those are the top two that kind of come to mind right now. I know there's probably more.
Right. So there's four main ones. The first one is prism ballast, which is what you're talking about. So these lenses have a thin apex up at the top and a thick base. Okay. Then there's peri-ballast, which these lenses have almost like a peripheral ramp where you will still get an inferior thickening, but it's got nothing really there in the center zone of the optic zone. So those two lenses are very dependent on gravity. Okay. So these type of lenses can be challenging on someone who has, fast head movements or eye movements, maybe someone who's playing sports, or maybe someone who has a slight head tilt, or like to watch TV while laying on their pillow, things like that. So something else that I think that needs to be taken into consideration with these two types is that a lot of these prism ballast designs can cause vertical prism. And we know that when we fit glasses, we have to pay close attention to all the little measurements that are taken within the glasses so that we don't induce any vertical prism, because even inducing 0.5 vertical prism can cause astinopia, headaches, and visual discomfort. So when fitting contact lenses, we need to take this into consideration too, because prism ballast and peri-ballast designs can all induce prism within our patients. So maybe if we're using those designs, the patient states that the lens is not comfortable because of that thicker bottom, or maybe the patient says visually the lens is not comfortable because of that induced prism. The third design is something called a dual thin zone. So instead of having the thickness at the bottom, it actually thins out the top and the bottom so that the thicker portion is in the middle. So the lid is supposed to grab the top and the bottom thinner, portions in order to stabilize the lens. The one that I like the most is the blink stabilized design. So this is a lens that is unique to the AccuView products. All of the astigmatism lenses that they have designed have what's called the blink stabilized design. So we know that when we blink, we don't just blink up and down, right? So in order for our top lid to meet our bottom lid, yes, it comes down, but it also comes kind of towards the nose or nasally. So this lens has that in mind, that with each blink, the lens is going to restabilize itself. So I find that my patients do a better job with the AccuView toric lenses because their vision is stable even after their blinks. A lot of patients, when you go to check their vision with certain lenses, they blink and then they're like, oh, wait, it's fuzzy right now. Give it a second, and then it kind of just has to stabilize. But those are the things that I take into consideration.
Yeah, it's good to think about the type of prism that the lens you're using or maybe pulling from your fitting set is going to introduce to the patient's eye, especially, for instance, for this patient, she only needs a toric lens in one eye. So if you choose a prism ballasted lens or a prism-based design, you could have that sort of vertical jump in one eye compared to the other, which can cause that disparity. So knowing how your lenses are stabilized is so important. I actually talk to my students about that a lot because sometimes it's easy to not think about that and you just pull whatever you can find. But especially when you have a unique patient like this, or maybe a patient who's having some trouble, it's good to have a sense of, okay, this manufacturer utilizes this type of toric stabilization system, and this one does this, because it might help you one way or the other. It might, if their patient is failing with one type, you might move to a different type. One thing I wanted to kind of rewind to, because you're totally right, Gaby, that a lot of doctors shy away from doing toric lenses because they assume it's going to take more time, or maybe they've had bad experience in the past. I want to ask Ryan, because he's not an old doctor like we are, right? Like, he's fresh. Like, in your experience, Ryan, have you found that torics take longer to fit than a spherical lens? I know you guys fit your classmates a lot. Obviously, you've worked with patients. What's your experience been like?
I honestly, in my experience, have not found any difference between fitting a toric and fitting a normal spherical soft contact lens. It's pretty much the same kind of procedure. You still have to do all the fit assessments and the over refractions and then the ocular health, but putting a toric lens on the eye doesn't seem to really make any significant time difference in really fitting the lens and getting the patient out of the room. It seems to be about the same amount of time to me, in my experience.
Yeah, I figured you would say that, because again, your only experience with soft torics is with the modern designs that are on the market today. And you haven't been able to develop those sort of like maybe negative perceptions around toric lenses that more established doctors have. So it's so good to say that and hear that, because it underlines how good most of the products are that we have available to us. And we just need to make sure that we're using them, right? So that our patients can get the most sort of maximized visual and ocular comfort and sort of best overall experience with their lenses. So awesome. I didn't even tell him I was going to ask him that. So,
and Dr. Erin, how many times have you heard patients say, I've worn astigmatism contact lenses before, but I can't see consistently out of them, or
yes,
those astigmatism lenses are very uncomfortable,
so
especially
much.
when you have one that has astigmatism and the other one doesn't, so it's really important that you take into consideration that not all toric lenses are designed the same. So the result is not going to be the same on every patient, but you got to
Exactly.
choose a lens that's comfortable and makes both eyes feel even, especially when you have one that's toric and one that's not.
For sure. And I've also had so many patients say to me, and I'm sure you've heard this too, oh, I have astigmatism. Someone told me I can't wear contact lenses. And that's almost, especially as I fit a lot of specialty lenses. I'm like, that's 100% false.
Not true.
Actually, if you have astigmatism, you should be wearing contact lenses.
Right.
And for most of our patients with regular astigmatism, there's multiple soft lens options for them that could work and correct their vision. So I actually kind of like it when a patient says that, because I know that I'm going to be able to do something for them that no one else has done. And it won't be that hard for me to do it, right? Like it's pretty easy and straightforward to fit a soft toric lens on those patients and really wow them, right? If someone's told them, if they've had this thought in their head for forever that like, I can't wear contacts or I can't achieve good vision with my contacts, it's just not true.
Right. And like you said before, now they're designed to accommodate different lifestyles, whether the person's an athlete or likes working out, or if they're a professional, or if they're, an outdoor enthusiast or like to travel. It really enhances the freedom and to be able to move around and that visual clarity with contact lenses rather than just being able to wear their glasses is really something that we should all be offering to our patients.
For sure. For sure. Yeah. Well, let's bring Daryl back in here. Is he hovering out in the?
I'm always ready. I'm just in the back saying,
I
put me
know.
in.
I know you're always ready.
Put me
I'm
in.
curious what your thoughts are about this topic and kind of the overall lifestyle effect of kind of bringing in these types of lenses for patients.
Yeah, I mean, I think you ladies nailed it, right? I mean, especially when you brought in the example of glasses and how you can induce prism. If you give any patient glasses and you've induced prism in their glasses, they will never come back to your practice. They will talk badly about how you refract patients, and it will make a major it'll have a major impact on your bottom line in your practice. So why would you do that in contact lens? You got to treat these patients the same. You have to make sure that they can see clearly, and the best way to do that is by having the right solutions. And most importantly, being knowledgeable about the different lens designs. I think it's very important to really hone in on that piece, because even as someone that has practiced for X amount of years, sometimes you forget about those designs and you just get into what's the latest and greatest and you prescribe that. But you really got to assess that patient. What do they do for a living? How far are they sitting from that monitor? Are they indoors? Are they outdoors? Is there a lens option that has blue light protection? Is there a lens option that has some type of, pupil optimized technology that's out there? How are you going to handle these patients that are sitting in front of you? And I think it all starts with having a fantastic history and understanding the different lens technology that's available out there. So I think you ladies nailed it.
Yeah.
And one more thing,
reps.
Something that I'll never forget that another doctor told me is, why would you do the spherical equivalent for that patient? You're essentially over minusing them. And we were always told in school, don't over minus your patients.
Right. That's a great point. Yeah.
Yeah, I agree. And I think something else too, Ryan, just to put you on a game, since you have some OGs up here on the call, is even if you don't wear contact lens, always put a lens on, see what it feels like. That way, when you're having a conversation with patients, you can kind of put yourself in their shoes. That way you can at least educate them on as far as the comfort, the how wet it is. You just want to be able to really connect with them in some kind of way. So I think it's very important to always try out the contact lens. Now, I'll let you guys in on a little secret. I don't like anything on my eyes, but I still try out the different options just to see what it feels like so that I can have that conversation with my patients. And the same thing with artificial tears. I know there's different types of dry eye that's out there, but you want to at least be able to connect with that patient that if it burns or if it's a milky substance, you want to kind of put them on a game. So when they leave your exam lane and they go home and they start using these products or services, they're not shocked by something that they experience because you've already educated them about what may happen down the road.
For sure. 100%.
Yeah, yeah. So, I'm curious. When it comes to having that conversation about astigmatism, I know we touched on this a little bit last time, but when you when you have a technology that's a hydrogel versus a silicone hydrogel, how do you bring that piece of the conversation in when you're talking about the different lens materials, or excuse me, the different lens designs as well?
Yeah, well, it depends on what you're suggesting to the patient. Obviously, a silicone hydrogel lens is going to allow a lot more oxygen to the eyes. And most of our premium lenses are going to be in a silicone hydrogel material. So if we're choosing a SiHy, I definitely am going to highlight that to a patient, that this is sort of letting the most oxygen to your cornea as possible. But for me, clinically, I'm most concerned about my patients getting in a daily disposable, and some of our dailies are hydrogel materials. And if that patient is compliant with those lenses, that lens is also going to allow enough oxygen to the eye to be healthy. And so the great thing is the lenses that are on the market today allow enough oxygen to the eye as long as the patient's compliant, not sleeping overnight in them. So if that's sort of the bonus benefit of a lens that my patient's wearing, that they're in a SiHy, that's great. But I also ensure that even if we're in a hydrogel material that's maybe a more approachable daily disposable, that they're still getting enough oxygen to the eye from a health standpoint.
That's great,
Yeah.
great feedback. And Ryan, I'm curious, do you always go to a silicone hydrogel material? Because I mean, you are the younger generation, right? So that's kind of all that you know, right? For the most part. Or maybe I'm wrong, but I grew up during the hydrogel material, then slowly transitioned into the SiHy material. But I'm curious to know, is that your go-to for every single patient that walks through the door?
Yeah, I would say so. Honestly, we learn in school, right, that the SiHy obviously is better for the eye in terms of ocular health and transmission the oxygen. So I think always, at least for me, I'm more comfortable reaching for a SiHy lens over a hydrogel lens when I'm fitting like a patient in clinic.
And for the expert panel, I'm curious to know, is there a case when you should provide that hydrogel material? Because I know the one thing that I love about Johnson & Johnson Vision products is that they're inclusive, right? They have an option for every patient that walks through your door. So I'm curious to know, what case, what scenario would you prescribe a hydrogel? Because we all sometimes get kind of lost in the sauce with the shiny new thing that's out there. But I do personally feel like there is always an opportunity for hydrogel option. So I'm curious to know what you ladies do.
Yeah, so I think hydrogel still has a place.
Mhm.
Obviously, like Dr. Erin had said, I will always try to pull for the silicone hydrogel first. But if I get any pushback on cost, then I will say, okay, yeah, there's another option that we can try, and then I will go for the hydrogel option. It's always about planting that seed in that patient's head. Now they've tried what is the best, and maybe next year they're ready to get that silicone hydrogel and upgrade. But definitely you want to try to switch all your patients out from frequent replacement, in my opinion, into a daily disposable lens when you're able to.
Same, Dr. Aaron.
Yeah, I would say I just hear because the academic in me just has to say this. Some people might say that a SiHy material would be more likely to cause things like GPC from like a modulus standpoint, or potentially from a deposit standpoint. That's again more of like the textbook reason. I think in practice and in real life, we see that our SiHy, like daily disposables, have lower moduluses, and they don't deposit as much as sort of like a raw SiHy might. But that said, if you had a patient who was maybe really struggling with allergy or GPC, you might consider putting them in a hydrogel material just to make sure you're kind of doing everything you possibly can. But again, in my practice, I found that if they're in a daily, it doesn't matter quite as much. That's just sort of anecdotally what I've noticed.
Yeah, and that's why I love to have these conversations, because we have someone that's in the academic world and we have someone that's out in that private practice world, and you see how you can take both sides
Yeah.
of this conversation and just implement it into your way of practicing and how you see patients. It's a lot of gems that have been dropped tonight, and I'm loving every single one of them. And I hope all the students out there, all the new graduates, and hell, even some of the seasoned optometrists are listening to these amazing pearls that Dr. Erin and Dr. Gaby are dropping, and future optometrists, Dr. Ryan as well. My team of expert panels, any last words that you like to share with our colleagues out there and our future colleagues in regards to this case?
I say that I like this case, and I kind of like that this is wrapping up our series this year, because it really underlines how you can't just look at clinical data. You can't just look at the case history. You have to kind of merge them all together and figure out how you can best serve your patient and how your patient can best kind of help themselves, so that everyone's happy and so that they're able to stay in contact lens wear comfortably in the long term. So you can't just be a robot like clinician or technician. You have to listen and have empathy and understand your patient's lifestyle in order to best serve them. So it's a great mentality to apply to obviously your contact lens practice, but really any clinical care.
Nice.
Yeah. As for me, you may be surprised by how much improvement your patient actually gets by switching them to a toric lens. So always try to reach for that toric if you're able to. And I totally agree with everything Erin just said. Yeah, you have to look at everything. As optometrists, we're detectives. So a patient comes in with a problem, and it's really important for us to address everything. Me personally, when my technicians write in all of the chief complaints in the exam, I make sure at the end I go back and I'm like, okay, did I address everything that patient came here for? And I also always end with, do you have any questions for me, or what questions do you have for me, so that we know that everyone's on the same page.
Wow. I mean, just powerful, especially that last line. What questions do you have for me? Because there are a lot of patients that leave that exam room when you don't offer that question, right? They leave the exam room and they will keep that question until next year, or they'll find another doctor because they didn't feel comfortable having that conversation and that dialogue with you as well. So I love it. I love it. I love it. Ryan, you got to lace us with something as well, my friend. I mean, I guess we can ask you, what have you learned from this amazing conversation today with these experts on the panel?
Well, I think the biggest thing is something that we're always taught in school is the 20 happy rule. Just because a patient comes in and may have great vision, 20/20 on the chart, doesn't necessarily mean their visual needs are met. So I think it's important to kind of address the patient, see what they need as a individual, and then go off from there to kind of make the patient happy with you as a provider.
I love it. I love it. Dr. Erin, I don't know what you're doing over at that school, but you've been bringing some rock star clinicians on this panel, and I'm super excited because, again, this is the future of eye care, right? We have to make sure that we take the time and invest in these students, invest in the future, because they're going to be the future leaders. They're going to be the future educators, and it's important for us to invest heavily in them. So thank you so much. So everyone, we have a giveaway. 3 $100 Amazon gift cards. Are we ready for this?
Let's do it.
Let's do it. All right. So our winners are Karen Wynn, Caitlin Zoe, Zoe Bowie. These are our winners. Sam from Defocus Media will email you the gift cards within the next 24 to 48 hours. Thank you so much, everyone, for tuning in. This has been a fantastic series. We are looking to bring this back again, either end of the year, maybe top of next year. Again, we want to thank our partners over at Johnson & Johnson for really holding us down, but again, for really investing in a profession. Without partners like that, our profession, we couldn't push it forward as far as we have. Any last words at all, Dr. Erin, because you've been holding us down from day one with this. Any last words before we close out this series?
Oh, I feel like I've talked a lot, but it's been a fun series. And again, I think we kind of rounded it out in a great way tonight. One thing I was thinking while you and Gaby were just talking, that question of what questions do you have for your patient? So many times a patient will look at me surprised that I asked them that. And I almost love it when they do that, because no one's asked them that before. And it's just a good reminder, to be centered around your patients and their needs. And I think that's really what we've talked about for the last 4 episodes.
Yeah, I can tell you that the reason why I do that now every single visit is because there was one patient who I was like, all right, great, have a great day. They're like, wait, you didn't ask if I had any questions. I was like, oh, okay, do you have any questions? I think it's hard because, like you said, some patients are more reserved and they don't want to ask their questions. Like for me, if I have a question, I'm going to ask it right away, so you kind of have to put yourself in their shoes. So now after every visit, what questions you
what
have for me.
questions do you have? It's a great one.
Yeah, and the one thing that I always do at the end of my exams is always state, if you have any questions, feel free to reach out to me. Feel free to contact me.
Yeah.
And when I tell you that my patients literally do that, I could be in the grocery store, they can hit me up on Instagram and my DMs, LinkedIn.
You give them your cell phone number, don't you, Daryl?
Well, you know what? Funny story. I had a few patients text me, and I found out because apparently my number is in our neighborhood directory or something like that, and they know that I'm an eye doctor. So I'm looking at my phone like, what the hell? How did they get my information? So yes, patients actually do text me. I do give my number out here and there, depending on what the case is.
Right.
Some people I get concerned about, and I just want to make sure that I'm giving them that extra care.
Yeah.
But all my colleagues out there, know that when it comes to optometry, you are working every day. You are making sure that your patients are in a good place. We have the best profession out there. And again, I want to thank everyone on this call. I want to thank Johnson & Johnson Vision for helping us put this together. Everyone out there, all my students, stay healthy, stay positive, stay blessed, and stay great. And until next time, peace. Hey, family, if you enjoyed this full podcast, don't miss out on more engaging content. Check out the next episode right here. And for the latest updates, hit that subscribe button and ring the notification bell. Your support means the world to us. Catch us in the next episode. Peace.